You'll remind me that I've got to stop recording at that point. It's all right. You can go and edit afterwards, can't you? But that's not the point. That's not the point. Great. So let's just wait a minute or so, and then we'll get ourselves going. So this is our second community of practice. It's exciting. We've got a few more in the diary and lots of other stuff coming up to share with you. But I think I'm just going to move on to our. I think we can get going. We've got a lot to get through, haven't we, Jen? I can just sense her. She's just saying, Caswell, get on with it. Okay, here I go. So yeah, so good afternoon, everyone, and welcome to the second of our drop-in sessions for our new evaluation and analysis community of practice, which we have set up as part of the NNHIP Intelligence Centre. I'm Rachel Caswell, and I'm an analyst in the strategy unit, and I lead the Midlands Analyst Network. And my role in the NNHIP Intelligence Centre is to develop this new community of practice with you, which will enable you to raise questions, learn from each other and us about topics relevant to your role, and to help you try and achieve the things you're trying to achieve locally as well. So I just look at today's agenda. We are going to be revisiting the measurement guide with Mike in a moment, with some of the questions that you've asked last time, and at the first community of practice that we had, and also the follow-up session which we had during that same week. So we'll go through some of those questions, and then it'll be over to Helen, who will cover some of the questions you raised about the Neighbourhood Index. We'll briefly talk about the next steps, so you're totally clear on what you need to be doing in the next few weeks, and then after that we'll turn the recording off and we'll have an open Q&A, and of course you can ask more questions about the topics we will have already covered at that point, or you can talk about anything new as well. But before we do that, we do of course have to know who we've got in the room today. So I'd be very grateful if you would just pop over to Slido. I'm going to share my screen. I am going to share my screen. So I'll stop sharing this one. I've got this habit of singing instructions to myself, which is perfectly normal, I think. That's perfectly. Oh look, there's somebody called Rachel who said hello. She must be a really great person. And she says she's the evaluation analysis community of practice lead. And she says hello. Hello. So we have Roselle, who also says hello. No, that was probably still me. Manik, hi. I remember Manik from last time, definitely came last time. We've got BI leads here. We've got PHM covered so far. I'm going to give you plenty of time to get there. I'm already set up. I'm already there. But if you're not, so if you just go to slido.com and go for that number 4220. If you're just entering in the room now and you're not on mute, if you could just pop yourself on mute, that would be great. Just to make it more enjoyable for the rest of us, so we can hear what we're saying. That's great. So hi, Steph. Hi, people from NHSE in the room. Excellent. Hi, Mike. We've got project manager. Hi, Bryony. Hi, Katrina. Hi, Jill. Hi, Bernie, who's one of our local coaches. So we do have local coaches are routinely invited to these sessions as our analysts. We've also extended the invitation to national coaches as well, and anybody else who you have forwarded this invitation to, who you feel this content will be relevant to and will help you in your role. So most popular roles are in fact coach, place coach, and lead as well. And at least one person has said hello. Hello, Tina. Hi, Josh. Okay, so just one more question for you, because I just simply want to know what is in fact your neighbourhood. So whereabouts, who are you representing, where do you work, and how many of the 43 have we got here? We've got Portsmouth, West Suffolk, St Helens, Dorset, Solihull, West Leicestershire, Nottingham City, Buckinghamshire, Stockton, Rotherham, Doncaster. I'm doing so well. Lambeth and Southwark, Stockport, Slough. I've got a lot of you represented. Croydon as well. Portsmouth and West Portsmouth is they've got at least 3 people here from Portsmouth. You clearly want to come here and tell us what you're doing right, or learn from others. It's a bit of both, I imagine, for everybody here. That's the whole point, isn't it, of these sessions, is to learn from each other. And yeah, the topics that we're covering today are the ones that we covered last time, because there's been a lot of questions generated, and we'll try best we can to cover some of those off and to make sure that you have enough information for yourselves locally. Great. So I will thank you for that. Thank you for so we've got 41 responses, but I don't know that that's 41 different responses, but let's say we got 40. I'm going to move on from that because that's brilliant. I will now stop sharing and we'll go back to our presentation, because we have, I know I can integrate these things, by the way. I know I can do it more. I can now be more slickerer, but I'm going to now hand over to Mike in a second, but just very, very briefly, just for those who are new in the room today, we created this because you thought it'd be a great idea to so we could come together and learn from one another. There's a couple of the things here that we said we would also try and achieve, which is sharing resources with you to help. Which we will be doing. We have a brand new one next time, which we're going to share with you. And the recordings, I should remind us, they are on the NNHIP website, which you can see there. And if there's any slides that we can share, we'll also put those on there too. The ones from last time are already on there. So I'm now going to hand over to, I've done the easy bit. I get the easy bit. I'm lucky. I'm going to hand over to Mike. I think he's here. I hope he's here.
Sorry, I can never work out how to mute my thing on my laptop. My cursor goes everywhere. So yeah, so I'm Mike Woodall. I'm leading on the measurement guide. So the kind of outcome metrics and the one process metric that's in there, and the development of the kind of support materials that go through it. So we go to the next slide. I'm going to talk you through the So I'm going to talk you through some of the questions we've had, just so we're clear on the requirements for the national measurement. So the first question we've had was, what data do places need to collect? So there's 15 measures, although some of them are subsets of other measures, that places have been asked to submit data on. These are detailed in the measurement guide, so the Word document that we shared, the summary guide, as well as in the data collection template. We've made a couple of changes to the data collection template based on feedback from people. So people have identified areas where it doesn't quite make sense. They've been updated, and that data is now available in the shared directory, so people can access that. But if anyone else wants it in the meantime, we can share that with you. We go to the next slide, Rachel. So there's other data that's being collected by the program. So these are the areas where you don't need to collect data locally, although you're very welcome to do so if you want. So the national measure for proms and prems is coming from the Neighbourhood Index, and we're going to hear from Helen about that soon. But if you wanted to, there's details in the measurement guide that would allow you to use things like LTCQ, ICE-CAP-A, EQ5D. So if you want to implement them locally because they fit better with the way that you're delivering your service, that's fine, but there's no national requirement for you to do that. And there's no requirement for you to submit data, even if you choose to use them locally. In terms of workforce engagement, an initial version of the collaborative behaviours assessment has already been sent out. So baseline has been taken, and we're looking to use that to measure workforce engagement within the programme. But obviously, if you have local staff surveys, if you want to use the NQPS, which is the National Quarterly something score, I can't remember. But before, yeah, so you can use that, and you can use other NHS workforce data sets if you want. But again, they are for local use and are not mandated nationally. So we move on to the next slide. And then the kind of which population of patients being asked to collect data on. Now, this is different for each site. So each place made the decision on what their local cohort would be. I know a lot are focusing on frailty, but there may be other things within that. And what we want to measure is that cohort. So the set of people that your program, your local project is aiming to improve the outcomes for. So it's that group that we're looking for. So not just the people that you engage with, but if you've got things like risk stratification tools to use and you've identified a population from them, we're looking to use that, and that can refresh over time. And then, sorry, we move to the next slide, Rachel. The data is required monthly. This is the kind of process it goes through, but ultimately, it's around 8 weeks following the end of the month, and that's to allow for a 6-week time lag in a lot of the national data sets. So there is time to do that. So the first monthly submission is due on the 27th of March to cover January 2026 data. And that's detailed in the measurement guide. There were a couple of versions that have been shared, but the latest version is the right one. So yeah, it's monthly data from the 27th of March, but the first data set will only cover January. Next slide, please. The next one was around, will you be able to view the measurement data that was being captured? And the answer is yes. We are developing a dashboard. It won't look like this version that Copilot drew for me this morning, but we are looking at that, and so that will allow some comparison across areas, and for you and the national team to track the outcomes over time. So that will be developed. We've got a session to start that process this week, and we're developing that through, but we'll bring kind of ideas for that to this group, and we'll make sure that it covers what both the national and local places need from this. Sorry, I've got to wave because I'm in a room where the light goes off if I don't move. So if we move to the next slide, Rachel. So yeah, sorry, this is a bit small, but this kind of just describes the steps that you need to go through to gather, collate, and submit your data. So the first thing is to identify your local cohorts. I think most places have already decided who they're targeting. But if you haven't, that you need to understand who you're targeting, both to deliver improvements, but also for measurement. Identifying an analyst to support that. So I know we've got a lot of analysts on this call, and a lot of places have identified that support. But yeah, for those who haven't, then you might want to look at what analytical support you've got locally. And just to remind you that we can help. So if there's any queries or questions that the analysts have, we can support through that. The next one is to actually identify your local cohort within data sets. So you may have agreed a set of rules, or you may have taken data from a risk stratification tool. But the next element is to then make sure that you can track those patients. And so ensuring that you've got data that shows which patients are in there is really important. And if you can't, then it may be that you require a kind of proxy for that. So if you can't identify the exact cohort, it may be that you can use other data to at least kind of replicate that as much as you can within the data. If you're using primary care data or other data sets to identify your cohort, then you'll need to link that with the outcomes data. So most of the outcomes data comes from acute and community data sets. So if you're using primary care data, you'll need to do that. But again, if that's not possible in your area, then we can talk to you about kind of options for mitigating that. You'll then calculate the outcomes data, so the outcomes that are defined in the spreadsheet that's been shared, and these give the overall levels and then some demographics. So age, deprivation, and ethnic group are all in there. So once you've got the data and it's collated, then you would complete the data collection template. So the first one would be data from January 2026. It would cover all the metrics in the group, including numerators and denominators. The sections in the spreadsheet that are yellow need to be completed. The other bits should calculate themselves because they're using things like denominator numbers. But you can overwrite that if necessary. So you would complete that spreadsheet, and then also there is a front page to it that asks for your place and the date. So you would complete that and the data. You would then run your own internal data quality processes and any sign off that you required. And then the submission is done via an email. So it's aggregate data that's emailed through to the main neighbourhood email address. And that's required by the 27th. And then we'll do some additional data processing and data checking from there. It's unlikely that we'll come up with much in the first month, but we will have a look at it and can provide support to you from there. And then next slide. So that process that I've talked you through there, we were wondering where different places have got to in terms of developing the data set. So we just wondered if you could respond in the chat with your place and where you think you've got to on that alignment. We're not expecting anybody to be at 8 because we know we've not got any data submitted yet. But I think the ones between 1 to 4, we're just wondering where people are on that journey. So I'll leave it there for a minute for people to respond. We'll move on.
Mike, there's already a couple of questions in the chat. I don't know if you want to pick them up now or kind of at a slightly later point when you get to the end of your presentation bit.
I think I'm at the end of my bit now. So we've got time for questions later, but I'm happy to take them now because we can save the time later. You want to go through the questions, Jenny?
Yeah, so Helen's asking about the process for small number suppression in relation to this process, I think.
Yeah, so we haven't provided any details on that. Let me just double check what we can take through. I would expect us to suppress anything under 5, but I just need to double check anything else, and we'll put that in the spreadsheet. So we'll get that out we'll work through that today, and make sure that that's in there.
Great. Let's let Janine come in, and then I'll pick up other things from the chat.
Yeah, it's a data sharing suppression question. So we've been talking to the health informatics service that supports our practices in terms of data collection, they can't share anything with us that has accounts of less than 6 in it. So we need to get some DSAs in place that allows practices to run the queries and share with us, but clearly they will be sharing with us data that's counts of 1 and 2 because we've got a tiny cohort. By the time we split the kind of 30 potential patients that they will be prioritising through the MDTs, through the programme, the numbers that we'll be submitting for each month will be really, really, really small. So we can put a DSA in place that will cover us for the practice sharing that data with the ICB. But then us as an ICB, as data controller, once it comes to us, we'll be looking to onward share with NHS England. So we just need to make sure that we wrap up covering everybody for the IG around this.
Okay, yeah, that's
Because
not a problem.
if we apply small number suppression, we'll be sending you a spreadsheet that's got a load of hashes in it and nothing else.
Yeah, I realise that some of these populations, certainly at the beginning, will be small. So I'll kind of double check what we're covered for at the moment, have a look at what we need to do, and get back to that. Sorry, it's not it's a question that hasn't come up so far from everybody, but I do understand what the kind of issues, and we can make sure that happens.
Thanks, Mike. Glenn has asked if a patient declines to be part of the NHIP programme, should they be excluded from the identified cohort count?
It's an interesting one. Initially we wanted to include the whole cohort so we could see what happened to them, and people refusing, I guess, is an interesting finding and looking at that. But obviously, can I think about that, and we'll send out a response.
That makes sense.
Yeah.
My
Sorry.
instinct is also on inclusion, but there's also something about that be different in relation to things that relate to opt-out and things. But in terms of measurement of impact, uptake is important, and refusing to be part is also important. Thanks. Just a bit of clarity. Quite a few of you have talked about, Katie's put a link to the SharePoint site where a lot of the resources and FAQs are, but I'm aware that not everybody will have access to that. So for clarity, we'll be sharing the slides and measurement information and various FAQs to everybody who's attended or accepted this meeting afterwards, and feel free to share on. The other thing, just picking up the baseline, the workforce questions that are in the chat. So there was, the programme team managed a process by which a survey was sent out, a 360-degree collaborative behaviour assessment back in the autumn of last year. And that was kind of centrally managed, and we are planning to repeat that again. We'll make sure that the results of that go back. I need to check exactly how those were shared and what's available to people, and make sure that that's happened. And we'll also do some analysis of what happens when we repeat that data. But in terms of workforce, that's the only kind of mandated bit, so it doesn't require data collection or action from sites. And as Mike said, there are kind of optional alternatives for you locally if you're interested in understanding staff activation, satisfaction, and various other factors. Those are available to you, but they're not being mandated through the programme. I don't know if I've missed any more questions, if anybody else is looking. I can see that there's a question about Neighbourhood Index, but I think that we've got Helen coming on to that next, so we should pick up that up in the next section. Helen.
Yeah, just a very quick one. Just on the new template, has the issue been fixed with the age ranges?
Yes. We do
Okay.
care about people aged 80 to 84, and sorry that we missed those
Yes.
out. We're quite good with numbers, but apparently counting is one of our downfalls occasionally.
Yeah, it's all sorted.
Okay. Are we ready to move on a little bit? Mac, I didn't know whether you wanted to, I mean, just have a quick look at the comments in the chat around what data submission steps people are at. Most people are at 3 and 4. There's that's probably an average is 3.5. So if you wanted, is that what you were expecting, Mike, at this stage, do you think?
Yeah, no, that's exactly what we're expecting.
Okay.
Because we're, it's going to run off January data, so actually being able to complete the spreadsheet probably isn't possible now. So actually, it's it's really good to see that that's happening.
Okay, so
we just want to make sure that everybody gets the support that they need to do that.
Yeah, sure. Okay, great. Okay, well, I think it's probably time to move on. So if that's okay, Mike, unless you wanted any. Oh, Katie has a hand up. Katie.
Sorry. I just saw Jamie's question pop up, and I wondered if we had a moment to respond to that. So it was about measuring outcomes and impact, and it being the eligible cohort and not the cohort who have simply the ones that have received the support through the INTs. So I don't want to fully answer that one. I maybe can start off and then Mike, you can jump in, but there are lots of discussions with NHS England about the evaluation approach that should be taken. And I take your point that there's something about, is the intervention itself effective? But I think because we're looking at the eligible cohort, it's in that thinking about, is the intervention effective more at this population level for your target cohort? So it's a slightly different evaluation question that it's answering, but I'm going to let Mike step in and see if he wants to clarify or add anything.
Yeah, so the reason why we're taking a cohort approach is because if you want to kind of look at historical data and project that forward, or use difference in difference approaches for your evaluation, you can't use the individuals that have been delivered a service because they're not in the pre-period. So it gives you a better idea about what's happening to the overall population. When you run the analysis may be important depending on how many people you're seeing from that cohort, and you may want to apply that into the future. So you may want to kind of think about whether you use the date that you started in any impact evaluation, or if you think about something kind of putting a delay in because you're seeing very few people at the start. But we can advise on that individually if you've got any queries.
Okay, thanks, Mike. If there's anything we've missed so far in the chat, we can pick that up in the Q&A later. So let's now move on to and welcome Helen.
Thank you. Thanks, everyone. If we can move on to, I think probably missed the next slide, and then we've got another title slide maybe, and then next slide, please. Sure. So we spoke through this the last couple of sessions, and we shared some content in the slides, but just a really quick reminder, and for anyone who's sort of new to this, I'll try and just give a quick summary, and then move on to some of the questions we've had so far, and any other questions people have got. But so the Neighbourhood Health Index, is a way of sort of measuring and evidence and the impact that we might be able to have through the Neighbourhood Health Implementation Programme. So we know the programme provides an opportunity to test and demonstrate the impact of left shift, the impact of providing proactive coordinated care, personalised care to individuals, and we want to understand what that means to people, what impact that has on sort of their reported experience outcomes, and as well as sort of quality markers, their service utilisation and demand factors. So to do that, so we need to evidence the impact of neighbourhood health services, we need to be able to track some cause and effect, and yeah, we sort of can use the Neighbourhood Health Index and Neighbourhood Health Survey to support some of that. So the Neighbourhood Health Index builds from our Neighbourhood Health Survey to give a targeted approach. So targeting specific individuals with multiple long-term conditions who are at risk of sort of avoidable hospitalisation and long lengths of stay. The index will link that patient-reported data received through survey responses with their health record, wider activity data to allow us to understand sort of the correlation between experience and those other factors. The survey will link to a carer survey. So for those patients who have unpaid carers, we would ask them to also tell us about their experiences, both with regards to the patient and their own experiences around support, and be able to link that to again understand how carers' experience relates to sort of the patients. Through the index, we want to provide through that linked data actionable insight. So we will, through the survey, look for we'll have consent to follow up with individuals in terms of further surveys, and that will give us an ability to track experience over time and see how that changes. But also explicit consent to follow up with individuals where they tell us they're happy to do that, and hopefully act on some of the data that we're seeing, to take steps to further impact the change and improvement for individuals. And then through the Neighbourhood Health Index, which is work that sort of, I guess we've been planning for a while and doing anyway, building off a pilot phase that we ran last year. We would be able to sort of create and demonstrate cohorts of individuals, so those both participating in the Neighbourhood Health Programme, and provide sort of comparison in data around the difference between those who participate and receiving neighbourhood interventions versus those that perhaps aren't. How we would do this, so we're working with CAS to identify a national cohort, applying the hospital frailty risk score, which identifies those at identifying those at medium and high risk of frailty, which we think is around about 1.9 million individuals. We have the opportunity to supplement that list locally, which is what we obviously been talking to this group about. So we could bring in local lists and also include them as part of the survey distribution. So local sites identifying who they would want to include in that via their local risk stratification tools. Our method for contact is sort of a digital first approach using the NHS app, followed up by SMS, email, but with paper surveys for those without digital contacts or who need paper. We will collect a range of data, health and wellbeing measures, including some of the ones Mike's talked about, so EQ5D, the wellbeing measure, and other questions around sort of care coordination, personalisation, etc. We will link responses and present them back in a national dashboard. So we will create a dashboard that will enable sort of role-based access for and sort of data visualization from sort of national system down to sort of neighborhood level, and allow local sites to sort of undertake further analysis and potentially where there is consent, sort of re-ID and take action. Next slide, please. We've had a few questions around governance, just really quickly. I guess just to confirm. So these are some of the main mechanisms that we've got in place for the project. So we've got Section 251, sort of full support for the national rollout of the index, and that's confirmed, and application reference there for anyone who wants to follow up on that. I'll share that with IG colleagues. We are just at the timings of doing an annual review. So just so people are aware, that is submitted and under review with CAG. We, in order to support the local list sort of supplementation, we've recently submitted an amendment for CAG,
to our original section 251, and that's for an additional, just to allow that additional flow, where people are able to do that. We are expecting a decision on that imminently. We aren't expecting any issues. Actually, we had a bit of correspondence from CAG just suggesting there's a bit of an issue with the National Service Desk updates to the DSBT, which we need to resolve. But otherwise, we think the amendment itself is fine, and we're hoping to get confirmation of that very, very soon. And then I think we've had a few questions around sort of how DPIA data flow diagrams, whether we can share those. So very happy to share those. We'll find the right mechanism for getting those out to the right people. DPIA, we've been working really closely with IG colleagues on so kind of, I guess, drafting in collaboration with them. It hasn't been submitted for final approval, and we're expecting to do that in the next week or so. So we've just been finalising some final points around some of this work. But yeah, kind of, we don't think there's any sort of major questions or any major outstanding points on that document. As they're working really closely with IG, so hopefully when we submit it, we expect kind of a couple of weeks to finalise that, but happy to share a draft sort of final version with sites as we go through that process.
Helen, we've got a hand up. Are you okay to take that question?
Yeah,
Janine?
Thank you. Sorry, just switching my camera on. Thanks, Helen. Can I just say well done for getting all of this through CAG? I know how difficult that can be, and hats off to you. So my professional experience is all within secondary use data sets. We did a bit of work with primary care. So the bit of my knowledge gap on this is, how do we physically identify the patients that have been through the MDT cohort, added to the registers so that they can be contacted via the NHS app to do the follow-up? How will that physically happen? And what are the things that we need to be putting in place through the system to facilitate and enable that to happen? Do we need to be sending NHS numbers off to you? Do we need, what is the IG that we need to put in place locally to support that? It's understanding the building blocks so that we're in the right position to be able to do this. And apologies if other people are actually thinking, actually, no, we're okay, we know how to do that. But this is the bit that I'm sat thinking, I don't know how to do this.
Yeah, so in terms of the, I don't know if it's so in terms of sharing lists, so lists up to ourselves, and we're using cohort as a service to run the national cohort. We would need NHS number and date of birth to be able to bring in and identify and sort of run the list for local sites. So that's what we need, and we can send a template, but it would just be those two fields fed up to us to be able to do that. At that point, we'd add a flag to show that they come from the local site. So then, and that would track through. So in the end survey results, we would know those patients who identified through local case finding tools, part of the NHIP programme, and those that were part of the national cohort. And I think just say that, there could be some crossover where they're both, then we should be able to identify that they were both, or predominantly flag them as a NHIP sort of intervention group.
So we need to put something in place whereby we're extracting the NHS number, date of birth from the GP systems and sending them off to national to support this happening. Completely accept that you've got the CAG section 251 coverage. Will GPs be submitting that directly to you, or do you see an intermediary step where it needs to come through the ICB to support that data collection?
So we were suggesting ICB or DISCO, on behalf of ICB, just as a bit of a collation of those lists, and to enable us to probably more easily track when we've got a complete set, kind of to do it at that level. But from the last couple of conversations, I think we want to pick that up. We want to have that conversation with each of the places, probably again with an ICB colleague, but to understand. So we recognise that this feels different for different ICBs, different places within ICBs. So we'd actually like, in one of my next slides is just to say, to give you a contact for who we should get in touch with at each ICB to be able to have that conversation. But I think there are options there around feeding the information through and collating that at ICB level and then sharing with us. Or if we don't have, I think the last slide was kind of talking about, I think our CAG approval and the amendment will cover everything, including sharing the lists up to CAS, but it doesn't necessarily include what you can do within your own place ICB in terms of sharing. So yeah, there's something to sort out in terms of if you can't share that with ICB, or ICB can't receive that, then we would have that conversation and look at how we share sort of the list from directly from the practice to us. So I think we want to kind of work with each side to understand that, to have a conversation across ICBs on what that would look like for each and what we can do to support basically those lists coming up. Obviously, if we so this slide talks about the options in doing that. If you can't share local lists, we talk about sort of local lists with NHS England, either through your ICB or directly from sites. We'd welcome a conversation on that, and there's a contact, like I say, in one of the slides to follow. But doing that allows us to allows you to specify who you want to include, but then allows us to pick everything up from that point forward. So it takes the burden away from issuing surveys locally, survey reminders. I guess it supports sort of a consistent approach to the way people will receive the survey, the methods that we're using, app, SMS, email, etc., paper surveys, provides access to our national helpline, etc. If we aren't able to do that, but people want to sort of include people and have those survey results as part of the sort of final data set, then we have thought about kind of being able to provide a survey link to sites so they could do that themselves. So we provide an open link that practices can send out to the patients. If they can't get the list to us, we can provide a link. They do that, and obviously they'd have to do that themselves and manage the sort of administration of the survey. So we were trying to take some of that burden away, but there is sort of a option too around providing the survey link directly. We'll provide a survey link to do that after issue and local approach to reminders, etc. Everything would then still come back into Ipsos as our survey provider and could form part of that final data set. And I guess just to say, because we've had some questions on this, either of those things will sit alongside the national rollout. So there will be data there for all places around that national cohort of those at intermediate high risk of frailty identified through the HFRS. So whether you do anything at all, share your list, send a survey link, or haven't got to that stage yet, there will be some data there from those in the national cohort for your place. Does that make sense?
Really helpful, thank you.
Okay, so Helen, we've moved your slides on, as you
Yeah.
can see.
Yeah.
How do you feel about that?
I've hopefully covered. I've hopefully covered some of that, but let's pick up on questions if I've done any of that
Sure.
a bit too quickly. If we could go on to, because I'll do some of it again in the FAQs. We can move on to
Sure.
the next slide. I remember what it says. Yes. So as I said, kind of appreciate people have different options and preferences for how they would identify the lists and be able to share them. We'd really like to pick that up in sort of further conversation with each ICB around what we can do for places within that ICB. So if I know people might not be on this call, if people could sort of look to help us in identifying the right people or point us to those and get in touch with Patricia, then we'll coordinate that and look to set some conversations up so we can talk people through this, on a bit more of a one-to-one basis and just understand what support needs might be needed or difficulties there might be in doing some of this. But hopefully we can kind of find a solution that works for each site where they want to be, want the survey to be gathered and providing those metrics. Next slide. So just pulling out a few of the FAQs, which will be shared, I think, very soon. But again, probably touching it, just to be really clear. So if ICBs can't access NHS numbers or date of birth, will practices or providers need to provide lists directly? I think yes, we're looking at ways how we do that. But yes, intend that they will be able to do that. And then alternative option is a survey link, where we can't get the lists, and or potentially we can get lists, but the survey link is helpful, including people who perhaps weren't identified at the exact time that we said we wanted lists by, which is to be confirmed. And again, I think we talked about some of this in the last couple of sessions, but timescales wise, we just want to understand what this looks like, what's feasible, and when some of those lists could be generated. Jenny.
I think that's right. Helen, I wonder if because we kind of introduced questions a little bit early, I think that there's maybe a benefit just to really, if we could go back just a couple of slides, Rachel, I think if we just pause for a moment on this kind of three, maybe back one more, well, there's kind of three options here. There is a significant benefit, I think, to being able to identify your local list, to targeting this this survey to your local cohort, particularly if the questions in the cohort over are, if you think that there's going to be significant benefit in understanding patient experience and managing the experience in that way with the information from the Neighbourhood Index. But those three options are there. The option that where you can share your list either from GPs directly or from ICBs does mean that you kind of get the full benefit of the rollout opportunity. So some of that, so the slightly, working through the app, potentially some paper or alternative means and additional support to places. That's the kind of gold standard. But this point that if you do not have capacity for that, there will still be data being collected for this cohort that are being nationally identified, and we will work through the options of where those overlap. So this grey option will be there too. And then the survey link approach doesn't require that sharing. So from kind of Fiona's email, like that could be sent at point of support or throughout, or through direct support, but it does mean that you don't get that kind of bulk opportunity to get baseline information or a larger sense of information for your cohort, and that it's an online survey that's being received. Is that fair, Helen? Have I
described that correctly? Yeah, no, absolutely. Yeah, that's helpful. Thanks, Jenny.
Thanks. Sorry, Rachel, we can go back to the FAQs, I think.
Yeah, hopefully covered these. And I think the reason we've done that sort of couple of slides, because these are the main things that we are hearing through the questions and through the sessions that we've had. But so I think we've said like all patients in the national cohort will be sent a survey regardless of local cohort definitions or involvement in the programme. So we will have data at the end of this for that national cohort for each of the places who are part of the NHIP. Yes, HFRS cohort results will be made available to teams. You'll get access, or relevant people will get access to the dashboard to be able to view that information and take further action where that's sort of needed or helpful. And then we had a few around, just put one on around sort of addressing inequalities and access to information. Just as the question sort of covered it most generally, but there'll be some more specific questions in the FAQs. But I guess just to say that the survey materials include a multi-language sheet or further information on how people can access or undertake the survey in different languages. That'll be provided with every mail, and whether email, e-letter, paper, SMS, whatever. The helpline will be available to all, and that will provide access to language line for those that need it to access the survey in other languages. And then the survey will also be available in other formats like easy print, easy read, large print, and paper where needed and where requested. So hopefully that just helps with some of that access and inequalities questions that we had. And then, yeah, a quick question. So similar to Mike's, just probably in the chat, just helpful to know if people have got views yet, or don't know. And that follow-up conversation perhaps would be most useful, and if which approach people think they kind of would be looking to undertake. So we said sort of, yeah, local cohort, survey link, both, or not sure yet. People could give us an idea of that. That would be useful.
So we're asking for if you could pop any responses in the
In
chat.
the chat, yeah.
Yeah.
But I think that's probably, is that the end of slides? If we want to move on to sort of questions as well, and people can be doing some of that alongside. Oh, next step, sorry, with Mike.
I think probably it's worth doing a few more neighbourhood index questions. And in response to the things in the chat, I think that it's, given the level of interest and the kind of in-between site learning, I think we will continue to record and share full recording if people are all right with that in this instance, because I think there's a lot of learning that comes from the questions. So I think that the benefit of keeping the recording on to share the learning, as opposed to encouraging kind of more conversation through turning the recording off, we're weighing more in the side of let's share the learning. So I don't know if there's things that we can pick up from the chat, or if you've put something in the chat that you think would be that we could pick up with Helen. Do you want to put your hand up for us?
I think people are just responding to the question as they've been instructed.
There's a question about conversation with discos. Mike, I don't know if you want to come in that. I guess you said we have, I guess, not with all discos. Of course, I don't think, but yeah, sort of have to some extent had that conversation with discos.
We've spoken to escrows, particularly about the flow from Ipsos back. But depending on the kind of one-to-one conversations that people have and what we learn from those, we could go back to kind of a central point at a Descro to share data at that point.
And we have a hand up as well. Would you like to ask a question?
Yes, please. I did type my question a little bit early. I couldn't wait, but it was in regard to the NNHIP index. So basically, my question is about the definition of the cohort. So as a place, we have defined the cohort, right? It's 2 to 4 long-term conditions. However, when we go to local cohorts, what I understand with local cohorts is the neighborhood or locality specific cohorts. We are not there yet. So basically my question is, for example, the generic place cohort is about 18,000 people. The specific cohorts, the neighborhood cohorts, would be something around 6,000 people, which makes huge difference. So what I need to understand is, are we expected to submit for the 18,000 people, the place cohort, the generic one, or the local neighborhood cohort, which will be around 6K?
Do you want me to answer that?
Yeah,
Yes,
come in, Mike. Yeah.
So ideally, it's the local cohort that matches with the other data sets of the 6,000 in your example, so that it's more specific to the program, to the NNHIP program. So yeah, it would be the 6,000, not the 18,000.
Okay.
Thank you. That helps. It's just I will have to raise the risk of being late in submitting that, given that neighborhoods haven't decided yet, haven't defined their cohorts. Thanks for that.
Okay.
Thank you for the question. Janine?
Sorry, I thought I had this straight, and now I don't think I had this straight. So the cohort that they've settled on for the integrated neighbourhood teams is about 550 50 patients, so it's a really, really small cohort. But I thought we would be submitting data on the patients that were actually off, so submitting the NHS number, date of birth for the follow-up just to the patients that had been through the integrated neighbourhood team process, because they have in effect given consent to be part of the programme, not to the ones that we haven't necessarily invited to the INT process and to be part of the programme. And I think what Mike just said is it would be the 550 that we would send the NHS numbers on, not the however many they see across the initial kind of 4-month period.
Ideally it would, to set a baseline for that population and to have a kind of baseline idea of the proms and prems for that 550. But I think we can pick up an individual conversation about how that
can we have a
works in each.
chat
I
about
think I think it's the chats that Alan's put out that will be important to kind of discuss in each area, and we may decide to agree slightly different approaches in some areas where it's kind of pragmatic to do something slightly different. But ideally, it would be that, and I think that would be better to support the kind of local knowledge of that population as well. And as you move through, then you can follow the same cohort over time, rather than having a kind of just the patients who've been seen at this point in time. But let's have local discussions and then work through that.
Thanks, Mike. Katie.
Sorry, waiting for my unmute to come on. I just wanted to add to that, that I've seen some questions coming through about, you know, how will we know if that larger target cohort, you know, whom within that has received the intervention. And Helen mentioned, I think when she was talking through, that they're exploring the sort of being able to provide that data back in an identifiable format. So if you have your list of patients who had received the intervention, that's something that they're working through and exploring a way of sharing that back, so you would be able to see that and have that data, not just for the whole eligible cohort, but be able to potentially pick up those that have been intervened on. Correct me if I'm wrong, Helen, but that's my understanding. That's something being explored.
I didn't know whether that was rhetorical. I'm assuming it's rhetorical because of the time.
Let's move on.
Yeah, we will we'll pick through the any unanswered questions and sort of bring them all together. We have got just enough time, I think, to hand back to Mike just to a couple of key points on what places need to be doing in the next few weeks. So what is the focus that should be places should be putting on in the next couple of weeks, few weeks? Mike.
Yeah, do you want to go to the next slide? Yeah, so the main thing is to collect and collate those activity-based outcomes and process metrics for your local target population. And the key date for that is to submit by the 27th of March. And we've provided the kind of measurement guidance submission templates as well as this community of practice, but we can provide support in any way that you need. So if there's anything that you need, please let us know and we will pick that up.
That's really helpful. So we'll go straight to Helen, if you've got a couple of points to raise with folks here.
Yeah, so just to let us know, if you, for that follow-on conversation, kind of who, if you can identify or speak with and ask them to contact us, who we're best to speak with regarding a discussion around sharing lists and how that might work for each ICB, that would be really helpful. If you haven't already done so, there is a link on the NHIP website to our dissent posters, which provide people with the opportunity to opt out from the survey, so asking people to just kind of promote that within their practices and ask for those to be displayed. So if anyone hasn't done that yet, it's helpful just reminded to kind of try and point GP practices to relevant GP practices to that, and then I guess based on some of the stuff Mike said, just start preparing with how we will identify that local cohort and who we include, and we need to just come back and clarify a bit more around sort of that and who should be in the cohort. We obviously will have those conversations on list sharing. We will provide access to some of the governance documents, find a way to do that for relevant people to access the DPIA data flows which have been requested. And there are a list of FAQs that we've collated from the last couple of sessions. We'll continue to update those with questions as they come in, and just make sure we do sort of a bit of a regular feed on those for people, and flag kind of what's new, so people can kind of review those quite quickly, but keep up to date on any further questions we're receiving.
That's really helpful, Helen. Thanks very much. So we've had a Q&A. We had it throughout the discussion today. So just slightly over time, but just before we close, and I just want to say thanks again to Helen and Mike and Jen for helping us through today's questions and sharing more information about what needs to be done next. So other useful resources, there's the Analyst Network, I mentioned last time a recording, which it wasn't then, it is now a recording, which is available on that site, which is about identifying and quantifying opportunities to reduce hospital activity and shift care. Now that was linked to the one which is going to be in the next couple of weeks as well, which is looking at the interactive version of that information. But there's a session tomorrow on recording ethnicity, and Mike knows all about that because he's leading that one. So that's going to be like the best huddle we've ever had, ever. So do come to that one if you're interested in, if you're an analyst in particular, and you're interested in using and you do any analysis on ethnicity data and you want to help us improve the recording of it as well. So thank you everyone for coming today. We've got lots to work through. We'll make sure we tie it all up and that all your questions are answered. And I'll see you again in a couple of weeks. We'll all see you again in a couple of weeks, and that is about this session which is mentioned on the screen here. So thank you, and well, the recording will be on the website. Enjoy the rest of your day. Thanks for spending the last hour and 3 minutes with us. Thanks everyone. Bye.